I am Mayor Lloyd Ireland from the University of Kentucky, an orthopedic surgeon. This presentation was done at the Essentials of Sports Medicine from Sideline to the Clinic, presented at ACSM Team Physician Course Part 2, February of 2017. This talk is on imaging. I'm going to show you some cases that I've taken care of and try to correlate the imaging, the physical exam, with what we find at the time of surgery. This will be mostly involving the knee, but I'll show a couple of ankle and foot cases. This is our menu of what we'll cover: patellar dislocation, skeletally immature meniscus tear, osteochondritis dissecans, extensor mechanism of the knee and the skeletally immature and skeletally mature, and also tumors. In the foot and ankle, we'll talk about toe fractures, skeletally immature, distal tibia, and talk about toe in the foot. Patellar dislocations create the quickest hemarthrosis for any reason after a knee injury. This is an individual that fell down steps and had immediate swelling. The upper left is an aspiration of her knee. When I do aspirations, I like to go behind the patella and use an 18-gauge needle to aspirate the hemarthrosis. We typically don't do aspirations that often for risk of infection, and also the hemarthrosis will come back because the reason they have this huge hemarthrosis is because of this fracture of the patella. So this fracture wasn't fixable, but you can see here where it's mainly articular cartilage. There's a small amount of cancellous bone. If there's more cancellous bone on it, or it involves more of the articulating surface, this may be able to be fixed. But the reason the hemarthrosis occurs acutely and it recurs is that you have this fracture that's intra-articular. So this is just examining the knee under anesthesia. So the patella goes laterally. Sometimes patients will think the patella goes medial, but the patella goes laterally, and there may be some whip action where the train goes laterally, but the track goes medially. This self-reduces in about 98% of cases. Rarely do we see a lateral patellar dislocation that doesn't reduce when the patient starts moving the knee around. So this is what her large hemarthrosis looks like. This is her loose body, which if you don't get an x-ray back posterior enough, you may miss this piece that started here and is now floating around in her knee. Again, unlikely that could be fixed since it's been displaced. So here's her normal patella, and this is a good example of what the hemarthrosis fills up way up into the suprapatellar pouch with blood. So patients oftentimes won't understand why it's way up there, but basically the capsule goes way up here and in the back, so it's like a big balloon, and the blood fills that whole balloon. So this is a massive hemarthrosis, and the number one reason for an acute massive hemarthrosis is a patellar dislocation. Other reasons would be an ACL tear that may not cause this amount of swelling this fast, another osteochondral injury, and with meniscal tears we see very little swelling usually, unless it's associated with an ACL tear. MCL injuries isolated usually do not have a hemarthrosis. So what happens with this mechanism? If this is medial, this is lateral. The patella piece comes off when the patella either dislocates or relocates. This shows where that loose body was lodged, and sometimes there can be injury to the lateral aspect. Usually it's non-articulating part of the lateral femoral condyle, so this is an impaction shear injury where there's another loose body that came off when that patellar piece, when the patella was lodged there, and this is what that piece looks like. It actually had floated to be in front of the anterior cruciate ligament. So this is where the piece was that got knocked off from the medial aspect of the patella. Sometime where there's one loose body, there'll be more than one loose body, so that's can come from the lateral aspect of the femur. So this is a diagram showing the mechanism where you can shear off a piece here. It may hide in the lateral gutter. You can also have an injury, an impaction injury, where you shear off a piece here. Usually it doesn't involve the weight-bearing area of the lateral femoral condyle, although it can. So when you do a scope, you have to look everywhere for one loose body or more and document what the articular cartilage damage is. This is a 17-year-old direct blow on the patella when she was ice skating. She had a previous injury 2 years before playing lacrosse, but had done okay in those interim 2 years. She had a moderate effusion. She didn't like it when we did luxation maneuvers, pushing the patella laterally. Her active range of motion was 10 to 60, and she had just had this injury a day before. These are her initial x-rays. What you can see is she has swelling in her knee. The suprapatellar pouch is full, so she has a hemarthrosis. No bony abnormalities. It doesn't look like the patella is tilted outward. There's no radiopaque loose bodies. This is her MRI scan. So you can see here where the articular cartilage of the patella, you see the articular cartilage there, and then it looks like there's a piece missing. So this is the articular cartilage of the medial patellar facet, and then it's like a tooth has been pulled out of this, so there's a piece missing. Suggestion that the piece might be over there. And this is her arthroscopic picture of that articular cartilage piece. So there wasn't anything on the plain x-rays. It's not bone. It's made out of articular cartilage. And basically the popliteal hiatus is right here. Loose bodies will tend to hide down in the popliteal hiatus. Where there's one loose body, there may be more. So this is the lateral meniscus going up into that gutter. The piece was a little too big to get down into the popliteus fossa. This shows the lateral femoral condyle, the articular cartilage, and then the loose body is sitting right there. The scope now is medial. We've got a grasper in to grab that piece in the gutter. Sometimes you have to tease it to be in an area where you can get it, because it'll tend to ping around. If you can get a little bite on it with the Schlesinger clamp, then you can bring it into the notch or somewhere else where you can more easily remove that piece. So now we've got it moved around into the notch. We've got a better bite on it, and then you have to make sure you have a big enough portal, a little mini arthrotomy sometime you have to do to remove the piece. So that we remove the piece, and now this is where the lesion is that the piece came from on our medial aspect of her patella. Just saucerize it, smooth it so there are no recurrent small articular cartilage new fragments. The piece didn't have any bone on it, it had been floating around, so this was not repairable. And this is just using a duck bell and a motorized resector to saucerize that bed of the parent lesion where this came from. And you can do in an acute situation, a microfracture to get a better fill of fibrocartilage in the patella. Doesn't work quite as well as with a femoral condyle defect, but this was done, and there was good bleeding of this in this acute situation. Got the fluid off now, and use the shaver to see what the bleeding occurs if we've gotten it down far enough. And there were two small beds of where the original injury occurred and where the pieces came from. Document the size, look at her patellar tracking. Her patellar tracking was central. No open procedure or realignment was done or necessary, and she did well following this arthroscopy. No recurrent dislocations, had full range of motion. This 10-year-old had pain in his right knee, complained of catching, locking sensation, and pain more on the outside than inside of his knee following martial arts. This was the monkey that accompanied him to surgery, who has a left knee problem but no name. These are his x-rays, right knee, left knee. Developmentally, everything looks fine. No evidence of OCD, no evidence of fracture or abnormality of the epiphyses. This is his sagittal view MRI scan. lateral side, there is some abnormal signal in the posterior aspect of the lateral meniscus. Again, the femur looks fine, no evidence of OCD. These are his coronal views, and you can see an abnormal signal in the lateral meniscus. The medial meniscus looks fine. This is the normal fluid that he had in his knee, perhaps a little more than he usually should have. But this definitely looks like a peripheral tear, vertical in orientation of his lateral meniscus. Arthroscopically, this is what his lateral meniscus looks like. Unfortunately, it looks a little beat up, so he did have a unstable, probably for a period of time, bucket handle tear of his lateral meniscus. You can see here in the back, the attachments are still there. So this kind of is like a hammock going around and round. It's connected in the posterior aspect and the anterior aspect. And this is what the meniscus tissue looked like. This is what his medial meniscus looks like. So you can see that looks completely normal. And then this is the back of his meniscus medially. So that looks normal. This is a chronic tear of the lateral meniscus. In somebody of his age, you want to save the meniscus if at all possible. The technique of doing this is his ACL that looked normal, is to reduce the meniscus tear and then do an inside-out meniscus repair. This is actually with an absorbable PDS suture. So an inside-out, meaning that these positioners are placed such that we do a vertical repair of this meniscus is a more stable construct. Sometimes I do horizontal, however best to coapt the tissues. A trephination is done to get better blood supply peripherally so this will heal. So this looks good and he ended up doing well, but we have concerns that he had a chronic meniscus tear. However, he did cooperate with us and didn't go back to martial arts for over a year, and he did fine. This is an almost 10-year-old male who has pain in his left knee. He's an avid soccer athlete. The pain is more medial. You can see developmentally his femur looks normal. There's no evidence of osteochondritis dissecans. This is his rather wide notch. This is a lateral view. This is actually on his warm-ups and is not a fixation or endo button, so he did have his warm-ups on when he had this x-ray done. This is the front view or the coronal view. Normal lateral meniscus should look like a wedge like that, triangle. You can see here where there's a gap, so he has a bucket handle tear displaced of his medial meniscus in a 10-year-old. So that gap, this is the periphery of the medial meniscus, and this is the displaced medial meniscus tear. This shows, again, a displaced medial meniscus and normal articular cartilage, normal epiphyses. This is his arthroscopic finding. The gap here, the meniscus belongs back there, so the red here is the capsule and the rim of the meniscus. So the goal is to get this better blood supply by either needling it or doing a trephination with a rasp and then putting that meniscus back to the periphery. This was a little irregularity on his patella, inferior pole of the patella. So groove, patella, and then this is the bed of the meniscus and the displaced meniscus medially. And again, inside-out repair is done. You can do a combination of vertical or horizontal sutures. Sometimes we do all inside in the posterior horn or fix the posterior horn by drilling through a jig to make that meniscus go back down toward the tibia. In his case, we used inside-out sutures, and he did well, returning to soccer after a year from his meniscus repair. This is a 16-year-old with osteochondritis dissecans of the medial femoral condyle. This can be seen on lateral view. So this is where the radiolucency is there. That's osteochondritis dissecans. This is the lateral aspect of the medial femoral condyle. Typically, this kind of hinges where the PCL is attached here on the femur, and then it'll be unstable in this area and stay connected here. MRI scans are helpful to tell us if this is an unstable lesion or a stable lesion. In younger individuals, sometimes immobilization and reducing repetitive trauma, basketball axial loading may allow this to heal in a non-operative way, but they do have to have activity modification. So this is the MRI scan. This is an older MRI scan, but you can see here how the lateral femoral condyle looks normal. In this medial femoral condyle, where there is a radiodensity here, is where the OCD lesion is. This was an unstable lesion. And this looks like this is this undulation of the medial femoral condyle. So this is the OCD piece. The remaining is the parent piece. And this is fixation with a smart nail. So you drill it first and then put the smart nail in. In this case, this was not taken down. Oftentimes this will be hinged where this is unstable and this is still connected. So you can see here where there's that little undulation is where the piece is. So you want to improve the blood supply with doing a drilling of this, either through the cartilage or through the metaphysis into the cartilage, retrograde or antegrade. And then this is after the piece has been fixated, and then you can see where this is the circumferential area of the OCD lesion itself. It is important to probe it, make sure it's stable to fixation, and usually we put 2 or 3 fixation devices in. And this is probing the piece after fixation has been done, making sure that it is appropriately fixated. This went back very nicely. This is looking at the posterior horn of the medial meniscus. That's the PCL right there. And so typically where the hinge occurs is it stays connected at the PCL, but unstable more toward the joint. Assessing the size of the lesion and the stability of the lesion. The lesion looks excellent with the position of it and the stability of it. And you can see where the tibial eminence may be a contributing factor to this based on this compressing this area that is an area of more soft articular cartilage and bone and repetitive trauma. This is a 16-year-old basketball athlete, no specific mechanism of injury. He plays a lot of basketball. He was complaining of pain in his right knee. His plain radiographs show a diffuse lateral femoral condyle osteochondritis dissecans lesion. You can see here where there's the normal shape of the medial femoral condyle. Lateral one should look similar. This is the normal lateral femoral condyle of his left knee. So see where there's sclerosis, doesn't look normal. And you can also see this as an extensive lesion of the lateral femoral condyle. Medial femoral condyle is usually a little more distal on the lateral x-ray. So this radiolucency is the OCD of his lateral femoral condyle. ACL looks completely normal. This looks a little abnormal on this oblique sagittal view, but the more impressive one is the coronal view. See involvement of the entire lateral femoral condyle. Medial looks normal, and this irregularity indicates chronicity and also abnormal shape to the lateral femoral condyle. Arthroscopically, this is what that lateral femoral condyle OCD lesion looks like. This is the anterior horn of his lateral meniscus, and you can see here kind of like a baby's butt indentation right there. That's where the unstable lesion is. It does look to be intact, so to get this to heal more favorably, we can do a drilling with a smooth K-wire this way or with a jig going the other way. One of the problems with it going this way is that that piece can be displaced. And this is doing the antegrade drilling of this to get better blood supply. This was stable. These are x-rays 4.5 months after his drilling, and you can see what a difference it looks like from the original x-rays. And then these are the x-rays 7 months after his drilling, and fortunately the femoral condyle shape and appearance is improving radiographically. We didn't let him play basketball for a year. Pay attention, don't let anybody trip you up, because they will.